Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Alex Lutz, the VP of Marketing at RUMC, as well as Dr. Loren Harris, who is the Chair of Surgery at RUMC, and Dan Ryan, the Advertising Director at the Staten Island Advance. Welcome.
Thanks. Thank you.
Through RUMC Connections, you will meet the fantastic doctors, nurses, and medical professionals that make our hospital thrive. We'll also provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. The Department of Surgery at Richmond University Medical Center has a long tradition of providing superior surgical services for the community. RUMC's team of surgeons, many of them board certified, perform comprehensive general and subspecialty surgeries. Over 10,000 surgical procedures a year are performed at RUMC in both an ambulatory and inpatient basis. The hospital has 11 operating suites equipped with the latest technology, including the Da Vinci robotic surgical system, which allows surgeons to treat patients more effectively and accurately, resulting in fewer complications and faster recovery times. In this episode, we continue our conversation with Dr. Loren Harris, Chair of Department of Surgery at Richmond University Medical Center. Last episode, we talked about robotic surgical services that are performed at RUMC. In this episode, we'll shift our focus a little to talk about RUMC's surgical department and the various services that are offered. So, Dr. Harris, can you tell us a little bit how the field of surgery changed since you performed your first procedure?
Well, my first procedure as an attending surgeon was in 1996. Probably September of 1996. And since that time, I think things have changed dramatically, not only from the surgical standpoint, but from the anesthetic standpoint, the nursing standpoint, what instruments we have, critical care of patients postoperatively. So, surgery doesn't happen in a vacuum. And the people who help us in the operating room, the nurses, the anesthesiologists, the circulators, all of those people are critical to the actual outcome of the operation. It's very similar to the military. For every guy carrying a gun, there are 5 people behind him who did all of the other things. The people who got the food services, the people who set up the tents for the camp. All those things are critical to getting the actual outcomes you want. So I would say, things have changed dramatically in those 25 years or more. I would say, to me, the biggest change was the advent and acceptance of minimally invasive techniques really across the board for surgery, not just in my field, but in all fields of surgery.
So, doctor, how long does an average procedure take?
Well, it all depends on what the procedure is. I would say that, and it all depends on what you find when you get there. We have a lot of preoperative imaging for a lot of different types of operations. And as much as I love to look at CAT scans and you think you can tell what's going on in there, until you actually are looking at the structures, you don't really know what you're up against. And that's the kind of the mystery of surgery in the sense that everything can look really good on the CAT scans, and then when you get there, everything's not so good. These operations, you're talking about robotic operations?
Yes.
Yeah, it varies. I mean, robotic cholecystectomies are one thing. They probably, I've never done one, but my guess is they probably take an hour. For me, robotic lobectomy, meaning that's an anatomic resection of a part of the lung, generally takes me about anywhere between 90 and 120 minutes. But a hiatal hernia might take me an hour and a half. So it all depends on what operation you're doing.
But it's significantly less from when you were growing up through the system.
Yeah, it's significantly less because the actual the actual performance of the lobectomy probably about the same open as it was robotic, but it's the opening and closing part. For me to close during a robot case, I put in a tube to suck the lung back up, and then I take my instruments out. We have four small incisions to close. Takes 15 minutes. When you have a thoracotomy can take take you half an hour or 40 minutes to close. So there's a lot, and getting the patient rolled over and extubated is more of an operation or more of a procedure when patients had a thoracotomy than when they've just had robotics. So, it does speed things up. It can vary depending on what the pathology is.
And you said earlier that this field is a practice. How do you stay at the top of the game? And do you weekly, daily? You're looking through publications. You're looking through. How do you stay at the forefront of your practice?
Well, there's a prolific literature out there. I mean, journals published, and obviously online. I get articles almost every day online that I read, and you can set these things up online where it'll notify you if a certain topic comes up that's been published. So you stay on top of the literature. Like I said before, review the anatomy, stay on your game. It's I guess in a way it's kind of like the professionals before they play a football game. They're looking at films the week before. It's pretty much the same thing.
Well, that was my next question. She was like, so let's say you're performing surgery tomorrow. Walk us through your what is your game day preparation before you even set foot in that operating room?
Well, I think the best thing for me anyway is I review the patient's chart and go over their medications, their past history, anything in their history that might affect what I'm doing or the postoperative plan in terms of medications or other things that I might have to provide for them. Obviously, you look at all the images that you have, and it usually is in the form of a CAT scan or a PET scan, or if you're doing a foregut case like a hiatal hernia, they may have had a barium swallow. Obviously, you want to look at that. So you review all the images, review the chart. Like I said before, I always review anatomy just to make sure that, okay, I'm doing this lobectomy. Let's look at the anatomy of that lobectomy. And I may go to YouTube and watch one or two. I have a set of videos that I like from people who are very experienced and have done thousands of these types of cases. Do a typical case, and I watch them do an atypical case for that lobe. If you find this, then here's a great little trick to use. And it's amazing that I watch them all the time, and every time I watch them, you learn something new.
And how critical in your preparation is actually the interaction with the patient before they actually go in and they see you, they hear, because they're nervous. They're
always nervous. Yep. And I don't blame them. And many of them are, just imagine yourself going under the knife. You're going to go to sleep, and these are potentially life-threatening procedures. They do have mortalities associated with them. So, what I do is I sit down with the patient and the family, I explain to them exactly what we're going to do and how we're going to do it, how many incisions I'm planning on making. And I always make sure that they understand that anytime you start out minimally invasive, there's always a chance you may have to convert to what's called an open operation. And for robotics, the most common reason for converting, people would say, because you get into bleeding. That's not the most common. It is a cause, of course, but it's not the most common. The most common is that you reach a point where you just can't, you're trying to dissect something out and you just can't do it. So it's failure, what we call failure to progress. And once you fail to progress for a certain period of time, there's no sense in making a career of it, so you wind up opening. According to the literature, somewhere around 2 or 3% chance of converting to an open operation. So this way, everybody understands, everybody knows what the risks and the benefits are. And usually that's the best way to go. And nobody's ever going to feel 100% comfortable going to the operating room, but you can make them feel as comfortable as possible and understand that this is the right thing to do for the disease that you have. They understand.
Jumping into the actual procedure day, what would you say that your mindset is, and how do you stay focused, especially if it's a lengthy procedure?
Well, you mean in the operating room? For some reason, I just become very focused when I'm in the operating room. I know what the next steps are. Once I start the operation, first thing is I don't take my phone into the operating room. because that would be horrible. Everybody stays focused. I make sure that the team stays focused. They don't start talking about what they're doing tonight for dinner, because that's not what we're there for. Yeah. If the nurses want to put on some music, we were talking about that. Yeah, that's fine. There have been plenty of studies showing that some surgeons actually do better when they put their music on. So when I trained, it was forbidden. You could not put music on the operating room because it was felt to be counterproductive. But most of the studies on that have shown that not to be true. So if the nurses want to put on some music, as long as it's, in the background, that's fine with me, because I'm not going to hear it anyway. Once I start operating, that's pretty much what I'm doing. Nobody's going to, break me out of it until we're done. In terms of the length of procedures, take days, like separating conjoined twins, and you have teams that come in and out of the operating room. That's not what we do. For standard cases that we do, these are 2, 3, 4 hours sometimes, depending on what you're doing. And honestly, when the procedure's over, you're like, wait a minute, that was 4 hours. So for the most part, it's okay. You just make sure to empty your bladder before you go in. You're generally okay. Yeah. And I've never really had that where I had to run out of the operating room to do something. Yeah. I would never do that.
And when you're, as a surgeon, and you're working on someone, what's that feeling when you know that what you've done has saved a life or positively affected that person's life for the future?
Well, I can't tell you. That's why I became a surgeon, because there's really nothing like it. And I think that, when you have that connection with your patient, and the patient, I have patients who come back to me, and I have one lady who I operated on 10 years ago who still comes to see me and is cancer-free. And that's great. It's just such a nice, it kind of makes your whole day. And it's very, very gratifying. And it's something that makes all the hard work worth it. That's what we're here for.
I'd love to know how you got your start in medicine. How did it all start for you? And when you were rotating your way through surgery, kind of what was that aha moment for you that you just knew that was right for you?
Well, I never actually even thought about being a surgeon when I was in college. I wanted to go to medical school, and my original thought was to become I really wanted to do neurology. I really loved neuroscience. I thought it was really fascinating. And when I got to medical school, I started going through, the different courses and so forth. And I changed my mind. I wanted to be a gastroenterologist, which I also find very fascinating. And I was in the Navy at that time. And each summer we would rotate to a different place. And between my second and third years of medical school, I went to Pensacola. And in Pensacola, I had signed up for a rotation at their hospital doing internal medicine. So I was really excited. When I got there, they told me that there were no spots in the internal medicine rotation, that I was going to have to do surgery. And, you're in the Navy. It's not like you can say, I'm not doing that, I'm going home. So it was, I saluted and I said, yes, sir. And I walked off to the surgery ward. Well, and I thought I was going to hate it. But it turns out that I really connected with these. There were a bunch of general surgeons there, and I really connected with these guys. And it was very, very interesting, because within 2 weeks I had bought the textbook and I was reading it at night. I just loved it. And it's kind of like when you go through college and, what are you going to do for your career? And you wind up taking a course in something and you kind of connect with the professor. And you say, yeah, I could see myself doing this. And you kind of get really interested and you dive into it. And that's what happened to me. I never looked back. Surgical training was, I loved my surgical training. I trained at NYU in the late, I started my internship in 87. Yeah, I loved it there. It was different than today in the sense that there were no limitation on work hours. And I worked a routine 100-hour week. And I loved it. I couldn't wait to get to the hospital. And we made rounds at 5 o'clock, and in the morning, and I would get home at, maybe 11 o'clock at night or 12 o'clock at night on the days I didn't have to take call. I loved it. And my wife and I lived a few blocks from the hospital. She was an internal medicine resident. Oh, okay. And we bought a 700 square foot apartment that we still live in today. and we had 2 kids, and we sectioned off the bedroom for a little child room, and it was great because I was never there, so it was really only 3 people living there, and but we've expanded it. We bought the apartment on either side over the last 20 years, so it's much bigger. And my kids are grown now, so they're gone. It was actually I would do my training over again, heartbeat. I loved it.
You mentioned you served in the Navy, so first of all, thank you for your service.
Thank you.
How did your military career prepare you for a career in the operating room?
Well, it's interesting because, I joined the Navy. I applied for a scholarship with the Navy because I couldn't afford medical school. I had gotten into NYU, but I couldn't afford it. And I really wanted to train at Bellevue. I dreamt my whole life of training at Bellevue because that was the place, right? The chairman of the department used to say the best place for a surgeon to train is on the battlefield, and about as close as you could get is Bellevue. So I always wanted to be there, and I couldn't afford it, and I applied for a scholarship with the Navy, which I thankfully got. I loved being in the Navy. I thought it was really fantastic. It was very regimented. Some people might not like that, but I did. I loved it. I went to officer basic training for officers. Had this 6'2" drill instructor yelling at me from 3 inches away. But once you got used to that kind of stuff, it was great, and the Navy treated you very well. It was really fantastic. In fact, they let me take time off for training because most people in my program had to train with the Navy, but the Navy didn't have thoracic training. So they let me stay where I was to do that, and they let me finish my service there, and then I was discharged in '87. So as I started my internship, but it was great. I think in many ways it helped in the sense that it gave you a sense of purpose, the dedication. It kind of instilled in you the idea that this is what you have to do today. Just keep your eye on that and get it done. And the never give up kind of attitude, because there are cases where you just have to, patient's not doing well, you have to take them back, or you just never get tired. You take care of that patient until everything's taken care of. I got a lot of that from my father, but also from the Navy.
So, Dr. Harris, you've shared with us how high stress your job and career can be. What do you do to decompress?
Well, I don't know. I don't really think of it as high stress. I just love what I do. There is some stress to it because you are dealing with people's lives.
It sounds terrifying.
So you have to take it very seriously. It can be terrifying. It's got its rewards. But in terms of relaxing, well, believe it or not, I've been riding motorcycles for about 25 years, and that's just my thing. So, in fact, I got my wife into it too, and she loves it even more than I do.
That's great.
I actually have 4.
Wow.
So, why have one when you have 4? So they're all Harley Davidsons. I have an older one. I have a '72 shovel head, and anybody who knows what a shovel head is means that you need to know how to wrench. They're not very reliable. So I do all my own work, and I just love that. It gives you that sense of purpose, and I just love doing it. And my wife and I, in fact, we're going to Sturgis in August for the 5th time, and we've made so many great friends. So it's very relaxing. So you work hard, but you should play hard too. And I tell my residents all the time that you get done with your residency, and your residency is 24/7. That's all you do. You eat, drink, think about surgery 24/7. And then you become an attending, and all of a sudden you find yourself having free time and nothing to do with it. You can get very depressed, and people can get very, melancholy that way. And I think you have to find a hobby, something that you love to do that gives you that outlet. Because there is stress, and I didn't mean to downplay it. There is stress, and you have to find a way. They talk about work-life balance. So you have to do that stuff. In fact, some days, I ride my bike to work. So if the weather's nice, I'll go to the garage and get the bike and ride that to work.
It's great.
Yeah, it's very relaxing. And I can't hear my cell phone on it. It's perfect.
You're off grid. I'd love to know, who were some of your mentors when you first started out as a surgeon, and maybe you can tell us some valuable lessons that you've learned throughout your career?
Well, I think, I'd have to say, the surgeons who trained me at NYU, they were kind of old world. They believed that the patient came first. You had to dedicate yourself. If you operate on a patient, you own that patient forever. In fact, the chairman of the department was a gentleman by the name of Frank Spencer. He's one of the fathers of cardiac and vascular surgery, actually. And he believed that once you operate on a patient, it was your patient, and he would have patients come back 10 years after he did their heart surgery with some complaint not even closely related to heart surgery, and he would admit them to his service. So he walked the walk. So, and that was very inspiring to me. And his way of his approach toward patient care, I thought you just don't see that anymore in many places. Yeah, very dedicated, and he didn't take no for an answer. And the residents know, I'm like that too. Well, we can't do that today. Well, why can't you do that today? You can do it today. Get it done. So that's the way you have to be, because patients rely on you for your care. So Dr. Spencer and the gentleman who ran the cardiac training program was also one of my mentors. Yeah. His name was Steve Colvin. He passed away in an untimely fashion a few years after I left, but he was an amazing surgeon, also very dedicated. So the gentleman who eventually became chairman of the department there, a guy by the name of Pachter, Leon Pachter, was also very much like that. And many of the residents, we fashioned ourselves after these people, and that was the whole idea. So that when we were done, we would go out and teach our residents and juniors to be that same way. Because it's so important, because people trust you. They put their lives in your hands, and they're the only ones taking the risk. So that was really important.
Tell us a little bit about the surgical department at RUMC and the colleagues that you have in that department.
Right. Well, I've tried to build a real quality department, and I'm actually very proud of the guys that are working for me. I have pretty much. Well, we're working on some new recruits, but I have some very, very skilled and experienced surgeons. My vice chairman is Alex Barkin. He's a bariatric surgeon trained in minimally invasive techniques in bariatrics as well. He also does general surgery. He really has been a shot in the arm to our hospital. When he got to RUMC, we were doing no bariatric surgery at that time. And we hired him with the idea of starting a bariatric program because, that's something that's in desperate need here on Staten Island. And that type of surgery definitely prolongs people's lives and makes their lives better. And not just the surgery, but the whole metabolic aspect of being of metabolic medicine. And he's very well versed in all of that kind of stuff. And he started doing the surgery, and we've since become a well-recognized center of excellence with his help. He has a partner also, Mike Zamatis, who's a few years behind him, but is up and coming, and he's actually does great work. One of the older surgeons, older meaning probably my age, Lance Jung is also an excellent, outstanding general surgeon, and he's the guy who's doing the vast majority of our robotic general surgery. I mean, he's very busy, and he does pretty much everything stem to stern. He's one of the few guys I would say, here's a true general surgeon. He does pretty much everything. I have one vascular surgeon. We're looking for another one, Zin Lee. is my vascular surgeon. He's also excellent, outstanding. In fact, I've been bragging about a recent case he did. He did a lady came in with a ruptured abdominal aneurysm, and he did her minimally invasively or fluoroscopically and put a stent in her, and she walked out of the hospital. So, which is not that common. You know, when I was training, ruptured aneurysms, half of them died. So, I mean, to me, that was just amazing. So, I mean, he's outstanding, and he's a good guy. I'll forgive him. He's a Marine, but okay. But he's a very good guy, and very well trained. And we've added ear, nose, and throat. Dr. Chris Lisi is here. He's been with us for a few years, and he does not only pediatrics but adults as well. He's outstanding. In fact, we're recruiting to get him a partner to do more complicated head and neck tumor type surgery. So I'm looking forward to building that aspect of our department. We have excellent orthopedic surgeons. We have neurosurgeons. Our neurosurgery department is growing in leaps and bounds. We do neurointervention. We do a lot of different types of neurosurgery that when I first got here in 2017, we weren't even doing. So it's a very exciting time to be at RUMC. We were going to talk about the new physical plant. The hospital is spending upwards of $300 million. It's just beautiful. I can see the new emergency room right outside of my office, and it's gorgeous. And they just opened that a few weeks ago, 35,000 square feet of really state-of-the-art space, 4 new trauma bays, which are just beautiful. You can almost do surgery. You probably could do surgery down there. And on the second floor, part of the reason I actually came back in 2017 was that they promised that they were going to build the 10 new operating rooms. And not only operating rooms, but there's a recovery area. There's a new lounge suite. It's just beautiful on the second floor of the emergency room. Not quite finished yet. I mean, probably going to open fall, late summer, early fall, but it's going to be fantastic. I'm hoping to have a second robot parked in there at that time. I'm working on that.
That'll be wonderful.
But yeah, we need. We're doing almost 450 robotic cases on one robot, and it's very hard to get robot time. So I really think that administrators and surgeons think very differently. Administrators, want you to show that you have the volume before they spend the money, and surgeons are exact opposite. So, I'm a big believer in the field of dreams, and I think that if you build it, they'll come. And the great thing about Staten Islanders is they want to stay on Staten Island for their care, and they believe in places like RUMC to give them top flight care, and I think that we're certainly doing that. And I think that if we add a second robot, pretty soon you won't be able to get on that one either. So the volume will come. You just have to build the program.
Well, it's wonderful that we're able to offer all of these services and service Staten Island without people having to go to the city.
Yeah.
We'd like to thank you again for
Thank you.
joining us today and for all that you do to keep us safe and healthy.
I appreciate it. Thank you.
If you have heard, there are highly skilled, experienced medical professionals ready to serve you at Richmond University Medical Center Surgical Department. To learn more about our service, please call 718-818-2420 or visit our website at rumcsi.org. That about does it for this episode of RUMC Connections. Thanks for joining us. I'm Meredith Gaskins.